Okay, so welcome everyone and good afternoon. Welcome to the 33rd session of the online Optom learning series. Let me introduce to you our speaker for today. Today we have Dr. Roji from the Philippines. And Dr. Roji has finished his Doctor of Optometry as well as the Masters from the Central Escolar University from the Philippines. He is currently working as a professor at the Central Escolar University, Manila. And he's into teaching the following subjects, which are public health, occupational optometry, contact lenses, specialty contact lenses, sports vision, as well as binocular vision. He has presented in various conventions and seminars, and he also holds a post as a vice president of the Philippine Society of Public Health and Occupational Optometry. And today he's going to talk to us about how do you manage ocular emergencies in an optometrical clinical setup. So thank you very much, Dr. Roji, and we welcome you for this session.
Thank you very much, FB. Good afternoon, everyone. I hope I'm clear enough. So my topic is actually, as mentioned earlier, a review on optometric clinical management on ocular emergency. So I'll start with a question. So do you as an optometrist have therapeutic prescribing rights in your country? Because this is very essential. Because I believe we are to comply with the current requirements of the state with the territory drugs and poison, whatever legislation in the jurisdiction that you are working or at. So because all of this is all about ocular emergency, so we have to know whether we are allowed to manipulate or do such interventions. So I think that's just a disclaimer. All right, so let's start. So ocular emergency, as defined, it is defined as any conditions in which early action is necessary to prevent severe or permanent damage to the eye. I think the key word here is it has the potential to cause permanent vision loss, which we do not want. So it's very essential that we recognize it and treat it well as soon as possible. Okay, so how should we as optometrists handle ocular emergencies? So according to CDC, there are 4 basic things, or the basics in dealing with an ocular trauma. So first, for us, do not panic. Stay calm. Always remember that the patient is already worried, and if we see them and we're also worried, the more they'll be worried. So always remember, stay calm and stay in control. Next is to take a good case history. So in this case, because it's an ocular emergency, you might want to have a separate form. Maybe you can have the emergency eye appointment triage form, wherein, as you can see here, you have the patient's detail, and then questions such as what happened, is the eye painful, how is your vision, any redness, sensitivity to light, and you may follow that, so it's going to be easier for you to triage. So next is, of course, taking VA. When it comes to taking VA, it's case-to-case basis. As we all know, there are some ocular emergencies that does not permit us to have the visual acuity test. So again, this is a case-to-case basis because this is your baseline. Next is, as I mentioned earlier, triage. Triage is very important because first let me define triage. Triage is the process of determining the priorities for action in an emergency, because in an emergency, it will vary the perspective of the patient. As it is emergency for them, then you as a doctor, you should know, as an optometrist, you should know, okay, is my patient's emergency a real emergency? So triage is very useful. It is used to establishing the order in which to carry out acts of medical assistance. So this would give you an idea of who to treat first and how to treat it. You know, in the WHO came up with this three categories under the ocular emergency. The first one is the emergency, which is requiring immediate emergency treatment. The second one is the priority, which requires a rapid assessment and treatment, and the non-urgent for the non-urgent cases. So next is, of course, follow-up. It is essential that as soon as you go through all of that, at the end of it all, you have to establish a good rapport with your patient. That's why you don't just refer or treat and then send them home and do not follow up. You know, in our practice, follow-up is very essential. We have to understand what is happening and what's going to happen and what has happened. And at the end of the day, you are actually creating a good relationship with them, and follow-up is as essential. Now, let's go through it. The common ocular emergencies. According to American Optometric Association, they listed the followings: eyelid laceration as part of the ocular emergencies. We also have the periorbital ecchymosis. We have the blowout fracture. We have the subconjunctival hemorrhage, the corneal aberration, the corneal foreign body, traumatic iritis, hyphema, dislocated lens, and traumatic retinal detachment. For the Academy of American Family Physician, they listed retinal tear or detachment, mechanical globe injury, and chemical eye injury as an ocular emergencies. Now, here in the Philippines, our Department of Health, together with F1+1 in the Philippine Eye Research, came up with this standard, or as you can see, a guideline. So you can see here, there's the green, yellow, red, and the blue. So what we're going to do now, we'll just go through the green, which is treat right away if you have an ocular emergency such as this or ocular condition such as this, and the red, which is to refer immediately. So let me go through it one by one. Again, as a disclaimer, our way of dealing with ocular emergency may differ from state to state, depending on the legislature or how the law permits you to intervene in such ocular emergencies. So let's have viral conjunctivitis. This is the eye redness with water discharge, usually with history of exposure. So the action that can be taken is to advise frequent hand washing and avoidance of hand-to-eye contact. So you have to observe and refer to ophthalmologist if not improved after 3 days. If yellowish discharge appears, if the law in your country permits, you may apply erythromycin eye ointment or tobramycin eye drop once, then after immediately refer to ophthalmologist. We also have the bacterial conjunctivitis, which is the eye redness with yellowish mucopurulent discharge. So the action that you can do is apply again, if you are permitted or allowed to, apply erythromycin eye ointment or tobramycin eye drop once, then immediately refer to ophthalmologist. We also have the neonatal conjunctivitis. In some cases, you would have mothers or some parents would bring their child with this condition. So the thing that you can do is apply erythromycin eye ointment once, again, refer immediately to ophthalmologist. Some subconjunctival hemorrhage, which is the bleeding on the sclera or the white part of the eye. So the action to be taken is to check the blood pressure first, and then apply cold compress over the closed eyelid. If recurrent, refer to a doctor for further evaluation so that they have a better insight of what's happening. Hordeolum, the palpable painful lump or mass on the eyelid, more visible upon eversion of the eyelid. So what you do is you give oral antibiotic, again, if permitted, or apply erythromycin eye ointment or tobramycin eye drop. If unimproved, after 3 days, you may refer to ophthalmologist. The Bito spots, which is the white foamy cheesy patch or spot on the conjunctiva caused by the accumulation of keratinized cells due to drying of conjunctiva. So what do we do? For 6 to 11 months old, if the law permits you to do intervention, you can give vitamin A initially, another dose after 24 hours, and one dose after 2 weeks. For 12 to 59 months, you may give the vitamin A initially, another dose after 24 hours, and one dose after 2 weeks. Then advised to eat vitamin A-rich foods. For blepharitis, the crusty eyelids or the red eye may be present. So the action is apply erythromycin eye ointment or tobramycin eye drop. Or if unimproved after 3 days, always refer to ophthalmologist. Or there's the what they say, if you're not sure, refer. Okay. So next we have the foreign body, which is usually lodged in the conjunctiva or the cornea, which causes redness, tearing, and discomfort in the eye. And vision may be a little hazy. This is mostly uncomfortable. So action can be, if possible, if you can attempt to remove by irrigation with clean water. After that, you may apply tobramycin eye drops once, then cover with protective eye shield, then refer to ophthalmologist. We also have glaucoma, which is the sudden red, painful eye with no discharge, may have blurring of vision, and may have a family history of glaucoma as you go through your case history. So what you do here is after checking using your slit lamp and finding through your case history that there's a possible glaucoma, you may refer immediately to ophthalmologist for further evaluation and management. Traumatic eye injuries, such as penetrating, perforating, or lacerating injuries of the eye, you may apply appropriate eye cover, then refer immediately to ophthalmologist. We have also the retinoblastoma. We have the malignant intraocular trauma that may manifest with leukorrhea, white pupillary reflex, and or strabismus. So what you do is refer immediately to ophthalmologist for further evaluation and for management. Chemical burns. When it comes to chemical burns, this is the accidental splashing of alkali or any acid preparations to the eye, causing severe pain or eye redness and blurring of vision. So as for this, immediate and continuous washing of the eye with clean running water for at least 5 liters for at least 30 minutes, and then refer immediately to ophthalmologist. When it comes to chemical eye burn, regardless whether it be alkali, acid, or even the standard pH, always remember, regardless of the chemical, patients with chemical burns or splashes need to be seen immediately. So this one is a real emergency. So what you do is instruct the patient or the helper of the patient to irrigate the patient immediately for 10 to 15 minutes before proceeding to the office or to your clinic, or refer them to emergency room nearest to their current location. Then ask patient to bring the chemical agent or provide a label identifying the contents of the source of the splash if possible. So have a pH paper which you must store out of direct sunlight, which is available for chemical injuries. Now, all the things I'm saying here is with the notion or with the knowledge that with the current situation now, all of this, as you meet your patient, we are suggested to come up with a new guideline wherein we are suggested to ask our patients to have an appointment first before they go to our clinic. In such ocular emergencies, also which requires immediate treatment. So because of the COVID, it's not as easy as they can just go to your clinic and you can just do all this intervention. We suggest that you do your triage first via the phone, wherein asking all this information. So what happened? So you can have a triage call wherein you can have questions, series of questions to be asked to the patients on what happened, and you may also tell them what can be done. So again, this is with the knowledge of, as you do all this intervention or treatment, you are following the new guideline as for the COVID-19 guidelines. Okay, so for the final recommendations, as you can see here, for the diagnosis, I have here the diagnosis for outpatient. So what you can do in, for example, there's a mechanical injury to the globe. Usually what you do is you, following again, there's a specific guidelines, you try to find out, again, via call, try to find out what happened, give them triaging questions, asking step by step on how it happened, as you try to analyze and you try to understand what just happened to them. And then, if possible, you can set a date for them to visit your clinic. Then when they're ready in your clinic, then you can do a slit lamp examinations, and wherein you can check especially the degree of the ocular emergency, or if there's is it a serious one? That's why triaging is very important. You need to see the damage of the injury. So we'll make sure that there's a protocol now with the COVID-19 guideline on how to use our slit lamp and use all this examination as much as possible. We don't come close. We don't do direct ophthalmology. You don't do direct manipulation. So in this case, just to be guided, you have to just remember to be guided. Now, what you can do is, as initial treatment, you can have the eye shield, if possible. Again, tonometry is contraindicated. Leave embedded foreign object in place. Again, this is case-to-case basis. If it's minor, and if there's a possibility for you to manipulate or do something, if you are permitted in your legislation or in your country that you are permitted to do so, then you may probably do the intervention. But if not, leave the embedded foreign and then refer to the ophthalmologist right away. You may schedule analgesia and update tetanus immunization. Again, all these things should be done again accordingly. If you are not permitted, always refer to an ophthalmologist. It's very essential that our referral system is working well. So again, this one will vary country to country. So what is applicable for us may not be applicable to other countries. Again, it's with the legislation. So it's according to the law in a certain country. Okay. Next, if there's a chemical burn, now, or a chemical injury. Now, for chemical injury, as I mentioned earlier, this is the thing that you should do right away. You have to make sure that you are able to do your first aid, wherein you have to wash or irrigate right away, regardless of the chemical. You have to do the eye irrigation. This is very essential. So that's the first step, which is the first aid. Now, if possible, before asking them to go to your clinic or to your office, you might want to ask them to bring with them the container or whatever the chemical that came in contact with their eyes. So that it's a lot easier instead of just asking them like, so what happened? There's a specific chemical. So what is this specific chemical? Some of the patients do not really understand that or do not know the specifics. So the best thing to do is just ask them to bring whatever containers or whatever bottle that the chemical came in with, so that you can assess well. And then continue eye wash. It's very essential that we ask the patient to do the continue eye wash until they reach the emergency, whether it's the emergency in a hospital or in your clinic or the clinic of an ophthalmologist. Now, the sources, of course, are the American Optometric Association, the Optometry Times, the Department of Health of the Philippines, the F1 Plus, the Philippine Eye Research Institute, the CDC, which is Centers for Disease Control and Prevention. I also made use of the Mayo Clinic, the Boston Optometry Students, the Academy of American Family Physician, and the CPSS for the distance learning course. So for the final thought, I think in an ocular emergency, it's very important to be ready. You know, that's the basic or what you should have as remember one of those basics. Number one is do not panic. You know, the patients are already in a panic mode. So make sure you are always calm and ready. So always be ready. Take time to train yourself and your staff. Now, this one, in the case of, for example, as I mentioned earlier, this is case to case according to the country. So if your the legislation in your country permits you or allows you to practice or prescribe or intervene medically, then you may do so. So if not, then you have to abide by the laws. Now, if you are, then it's there's always, even if you are not, it's always nice to take time to train yourself. If you're not trained yet, I strongly suggest that you start training now. As one doctor mentioned the last time I was in a convention, he said the best time for you to handle ocular emergency is to be ready and to be trained. So you should be trained and trained early, to be trained early rather than to be trained later. Because you know these are ocular emergencies. You don't know what's going to happen. You know, though we know that most of the practice are just bound or limited to plainly refraction or spectacle dispensing. You know, but ocular emergencies, as mentioned, you know, we optometrists are the primary eye, or we are the eye care practitioners. We are the primary health care giver. So meaning optometrists are the best people to go to when it comes to ocular emergency. Instead of patients going to an emergency room or you know, go to the hospital, because we can we as optometrists, we know better on how to refer. So before doing all of that, you know, first aids, doing all the things that we can do before referring them, rather than just sending them to the ER. Wherein, of course, as they say, sometimes when you go to ER, it takes a while before you get to be attended. So maybe this is the time wherein we need to understand that we need to train ourselves. And if you have staff in your office or you have staff in your clinic, train them well, because these are the first aids. These are the things that you can do prior to referring them to the ophthalmologist or to the hospital. Because we are the primary care eye caregiver, so they should always first option. They should also remember that optometrists should always be the first option to go to, because we are knowledgeable in the referral system. We can assess first and then refer them. So at least it buys time. Next is the know when to treat and to refer. Again, if there's in a nutshell, or if there's a golden rule, if you do not know what to do, or always know when to refer. Again, if it's beyond you, sometimes we try to experiment things, which is all right. I mean, we try to learn new things. It's all right. But in a nutshell, if you are not sure of what you're gonna do, it make the damage even worse. So I guess instead of helping, you are adding up to the injury. So when you are not trained well and you do not know what to do, I think it's very essential to understand. The thing is, assess, and if this is beyond you and you think this is not within your responsibility or within your scope, then always refer. I think that's the key here. Now, I just wanna leave you with this 5 P's. I think I always use this in all of my endeavors. It's the proper preparation prevents poor practice. Again, the readiness. If you are ready, if you are trained, and if you are knowledgeable, we can help, and you can save your patient's eyesight. Because ocular emergencies can, if not treated well, can cause damage. To the worst is blindness. So again, I would like to thank you for joining us and listening to us. Thank you very much. FB?
Yes, thank you, Dr. Rojai. I think it was a very clear and a wonderful presentation, to be very precise. Thank you very much for your time. I think let's take some questions which are on the floor. So you could type your questions. Any attendees have any questions or anything? Because here what Dr. Rojai has done is he's actually given an overview about how ocular emergencies are being looked at the Philippines, right? So I think it would differ from the country you belong to. And if you have any questions, we are ready to take that.
Yes, there's one here when we were asking for our first question, like, are
Yes.
you allowed to do, therapeutic management? And according here, some countries are not also allowed. So, but
Yes.
according to Azrin,
Professor Azrin,
yeah, maybe, because there's part of in the U.S. some states are already doing therapeutic. I believe also in Australia, and as a matter of fact, in Canada, what they do there's a certain protocol before they meet the ophthalmologist. As a basic, they always, as a protocol, they always go through the optometrist first, because we are the base, the primary. So there's a certain protocol that they observe. So optometrist first, and then if it's within within our scope or capabilities, we go through that. I think that's the hope of all the optometrists uh, everywhere, right?
Yeah, that's right. That's right. I mean, we look forward to that model in each country where, you know, we are actually primary eye health practitioners, and we are the first line of defense when it comes
Right,
to, you
correct.
know, when the patient comes to us. And I mean, that's an ideal world or an ideal scenario where we want patients to come to us first, and we would do whatever is possible on our hand and do a proper referral channel or refer the patients appropriately. There's one question. Any thoughts on contact lens wear related to emergencies? Like if patients have sudden red eyes or lens-related injuries, what's your
Okay.
take on that?
Okay, when it comes to contact lenses, I think the first thing that you do in all of your emergency, whether there's a pain or you feel like discomfort, especially if unbearable pain or discomfort, there's redness. The first thing is to take out. That's the first thing you do. You always take out your contact lens right away. Again, this is just for cases of wearing contact lenses. But if I just I just have to clarify when it comes to having, for example, an eye injury and you're wearing contact lenses. There are some situations wherein you are, or that we ask the patient not to do anything, not to remove the contact lens, and let the manipulation be done by a specialist, or in our case, it can be optometrist or the ophthalmologist. Again, the first thing that you do when it comes to contact lens uh, injury or contact lens related problem, remove the contact lens right away.
That's right. Yeah. Allergic conditions in this COVID, how do you manage if that's related to COVID? Do you have any experience? And
Okay,
yeah,
okay. As per COVID, I must say that our situation now is very different. Even in the U.S., there is this state that I always check, the one in Manhattan. All the optometrists there are actually already capable of therapeutic. You know, they can conduct treatment for ocular emergencies. But the thing here is most of them are actually closed right now for the reason we are very careful now with this is more on uh, there's an extra care that you have to understand. This is not just like in the old days or when it was still during the normal, because we have the new normal. So you have to be extra careful in dealing with that. I suggest first, whenever the patient would have some complaints such as allergic or any itching or any discomfort, we suggest that you have a triage call, as I mentioned earlier. Triaging is very important. So base it on an appointment. So ask them as soon as you gather all the information. Ask them as if is it the first time, how severe or how itchy or how discomfort. After doing that, you have to probe. You have to ask. In our cases, we don't see the patients right away. We try to ask a lot first via phone. So after asking all of that, and then if based on your case history, that's why it's really important. The case history is so important in every management. Case history is very important because you would know, is this redness more than allergy? Because there are some signs and symptoms. They may be both like redness, but if as you can see, if it's like in COVID, as they say, it appears as if it's just a plain conjunctivitis, but once you check it, it's not. It's more on ADK. So what you do now is you can also have the COVID guideline first. I think this is because we need to be very safe. Not to scare everyone. There are some of our colleagues, especially abroad, who were victims of COVID. I think we have to be very careful when it comes to dealing with patients like that, because this is something that you can get easily. That's why you have to be careful. So if by the case history you found out that this is just the patient has a history of having allergy, or the degree of the discomfort falls under the signs and symptoms of allergy, then you may want via the phone. You may give them the proper medications. I hope yeah, I hope I answered that.
Yeah. The other question is, any objective method of how you might differentiate between an alkali or an acid burn?
Okay, so the alkali, you would know the difference again, because chemical burns or chemical splash will be basically the same when it comes to the emergency call. So the determining factor would be, you would ask the patient, what are you knowledgeable of what type of chemical that came in contact with your eye? Is it like, for example, alkali would be a high pH, such as, like, example is the battery, the the what do you call that? The battery, water battery,
Battery
liquid
water or
battery,
something, the
you
liquid,
know?
yeah.
Yes, that's alkali. So you already know that this is, by the way, alkali is the most damaging. You have to understand there's a level of seriousness when it comes to chemical burns. First, and the most dangerous is the alkali. Once you have the alkali, you already know that this is like a major emergency, because this one is the most dangerous form of chemical. So what you do, you ask the patient, you probe by asking. So are you knowledgeable of the chemical that came in contact with your eye? So they would give you a sample. For example, it's a detergent, so you'd know, okay, that's not alkali. If it's like a battery, let me go through it. I have a let me just go through it for better.
Yes, sure.
Yeah, if you don't mind, just stay there. Can you go to alkali? The alkali, the acid, and let me just go through it in triage. No. Let me just go through it for a while. Wait up. So that I think I can share some insights on that. All right, here we go.
Yes.
You can see my screen.
Yeah, I think the screen is paused. Probably we'll have to.
Oh, okay, wait up. Okay. And let me just pull it up. Okay, let me just go through it. Okay. There you go. Can you see it now?
No, yes, that's right. Alkali burns.
Yeah, can
That's
you
right.
see it? All right. So this is an example of alkali burns. These burns are high pH. So for the question, how would you know if it's alkali? You can have the sodium hydroxide and ammonium hydroxide. So if you ask them, they say, I think the container or the bottle says it's like ammonium. Oh, okay, then you should be aware. Okay, so this is more of alkali burns. Okay, so as examples here, we have the ammonia, drain cleaners, oven cleaners, and some fertilizers. Those are examples of alkali burns. Now for the acid, For the acid, you have, which is on the lower pH, which is less serious. So, but of course, again, any type of chemical burn is already emergency, okay? So these examples are the vinegar, and then again, this is for the acid, no, battery acid, the battery acid. Okay, and then the last one is okay, irritant burns, such as you know everyday irritants, pepper spray, household detergents, and whatnot. So what you do now, the best thing that we can do is just ask the patients to describe to us which type of container. You know, as a giveaway, usually container comes in color coding also. If you see it in a with a red label or red cap, it means this is really dangerous. So with that, that could help. And then we ask them to bring the bottles or containers with them as we see them in our clinics.
Yeah, I think that's important if we can, do a quick history and ask them to bring along. Is there any relationship between diabetes and recurrent STI?
Okay.
Will it be an
When it
ocular
comes to,
emergency as well? Yeah.
I'm sorry.
Because STI is also considered to be an ocular emergency, so I think that's why the questions comes out. Yeah.
Okay. Okay. So when it comes to STI, well, what do we do? Is that the question?
The question is the relationship between diabetes and recurrent STI.
Okay. The
Diabetes.
relationship again.
Yeah.
When it comes to diabetes in their current state, if the question is as an ocular emergency, if you have a patient and you already know that you have the baseline that your patient is actually diabetic, in your record you already know that this is a recurrent. So it happens associated with diabetes. It happens. There are times like it's like it's no longer considered when it comes to triaging. It's no longer considered as emergency. There's what you call the true emergency against the you know uh, under routine or under non-urgent conditions.
Okay.
I think that's my take on that. I hope I answered that.
Yeah, I think that should be good. And just to add on about the alkali and the acid burn question, I think we have some comment here which says that the alkali burn penetrates to the ocular media of the eye, whereas the acid usually damages the ocular surface or the skin.
Yeah.
So this is just an add-on to what you have already explained to us. So I think, yeah, thank you very much.
Yeah.
Yeah. So thank you very much, Dr. Rojai. I think we have taken all of the questions, and thank you for the very informative session today. We thank you from the team Online Optom Learning Series for taking out the time today.
Thank you very much. It's my honor.
And I'm just going to share my screen, Dr. Rojai, to just let everybody know what do we have tomorrow. And there you go. So we do have a session tomorrow. We have Dr. Mustafa Parekh. He's an ophthalmologist from India, and he is going to talk to us about what are the allergic eye diseases, what are the signs and symptoms, and how would you commonly manage those eye conditions. So tune in tomorrow, 4 p.m. Indian time and 6:30 in the evening Malaysian time. Until then, stay home, stay safe, and see you all again tomorrow. Bye.